Good evening, everyone. Welcome. You all look amazing. This is amazing crowd here. Thank you very much for coming and joining us all. This is our journey to a very complex organization. And I'm reminded of a term we call as a science of emergence. And for them who must be wondering what is the science of emergence, this refers to how we study complex systems and how complex systems exhibit completely unique properties and behaviors that cannot be predicted or comprehended by individual units. And it exemplifies how the whole is greater than the sum of its parts. And indeed, as a health system, we are extremely complex. And today, what we are witnessing is the emergence of a health system into what's going to be our future. I would like to thank the leadership at the school, hospital, the health system for allowing us to envision a future here altogether. We started back in 2021 when I joined here. We started with a small vision, and we call it as a deep vision. The idea was to drive transformation and innovation in cardiovascular education, research, clinical care, engage the academia and the community together to optimize cardiovascular healthcare delivery, enable our standing in regional, national, and international identity as a cardiovascular innovation model, and promote new knowledge generation. This was the whole theme with which I wrote my vision that brought me up here onto the stage. And at the time, we didn't have the cardiovascular service line. And I'm so amazed with the commitment and the journey that we have seen together from that day onwards today here. And I'm just reminded of our whole idea to bring people together. We were, since the beginning, always committed to the integration of people. And this is back in November 3rd, 2021 in Somerset Park, where the medical group first came together to discuss how we will be working together as a unit and how we are going to align in our education, research, and clinical care strategy. And today, you must be seeing the theme is the same roundtable appearance. And I'm so much reminded of what went around and how we were able to bring together our vision so far. Thanks to the combined search from the school and the health system that spearheaded a significant change this year. Dean Murta and Mr. Michael Prelitsky, CEO of the cardiac service line for the health system, and many other leaders were instrumental to shape our journey going forwards by creating the cardiovascular service line. And it's my distinguished pleasure today to welcome several of the leaders who are starting this month. And I'm really honored to also mention that, that the division has created a portfolio of education and research opportunities that is present on the YouTube. The whole idea when we sat together in the cardiovascular service line was how we could make this education environment be available to everyone. And these are the YouTube videos when we started 2021, they're all there. And imagine they have been visited hundreds of and thousands number of times, and what it does in permeating our environment to the outside world and being a beacon of how we want to expand and be known for. Today, we bring in our leadership and we welcome three leaders. Dr. Connor Barrett joins us as the Senior Vice President of the Heart and Vascular Service Line. Connor is here, and Connor, would you rise for us and so that we can welcome you? There you are. Welcome. Connor joins us from Massachusetts General Hospital, where he served as the Associate Chief of Cardiology Director for Clinical Operations and Strategy and Physician Director of Network Development and Integration for the Heart Center. And we are so excited by his leadership there, and we've been hearing about him from multiple of my colleagues from Mass General. So we are really looking forward to working with you, Connor. Carolyn Vincenzino, Vice President of Operations. Carolyn, welcome. She brings in 10 years of leadership experience as the former director of the cardiovascular service line from the New York Presbyterian. We are really honored to have you here. And Kulpreet Bhan. Kulpreet Bhan is the director. Kulpreet Kulprit Ban is the director of the heart failure, and he's going to work very closely with our leadership, clinical leadership, and executive team on several of the goals, aspirational goals that we have set for the heart failure transplant and the LVAD program. And with that small introduction, we're going to have a small event to signify how important this coming together of all the leadership and all the environment for the cardiovascular service line is here. And to signify here, we'll have a small ceremony. We call that the lighting of the lamp. And in a way, it signifies, the lamp signifies knowledge and wisdom. And it's symbolic of moment that signifies the dispelling of darkness and igniting of thoughts and enlightenment. Witnessing the lamp being lit may inspire us all. And for that, I'm going to invite some of the leaders to come forward. And there is no specific order. I just chose people who have really been instrumental in bringing us to this journey. Dr. Sergio Waxman, Chief of NBI, will join. Please come on over and be on the one side here. Then we will have Dr. Alfonso Waller, Chief of Cardiology from New Jersey Medical School. Dr. Anthony Altabelli, a Clinical Chief of Cardiology from Rutgers Robert Wood Johnson University Hospital. Anthony has been pivotal in the success that we have had in our division's work so far here, and look forward to continuing that moving forward. And Dr. Rachna Kulkarni, Director of the Women's Heart Program and Preventive Cardiology from Medcor. Rachna, not many will know, is a close colleague and friend. We come back from the same medical school in Nagpur, and she was the first person I called when I signed up for the interviews. Thank you, Rachna, for all the foundational help that you have provided. And also we will bring together a panel of people who are representing the leadership. Connor Barrett, Kuldeep Ban, and any chiefs of cardiology or cardiothoracic surgery I'm missing here, please come up on the dais if I'm missing, because this is the moment we'll go to sign up and spread it out, because this is going to be shown as a moment of integrity. And I'm going to mention that, so there's going to be 5 candles that will be lit, and there'll be a lamp that will be lit. And the flames upward moment, defying gravity, stand as a symbol of our quest for knowledge, upliftment, and the resolve to rise above all challenges. It will stand as a testament to the power of light over darkness, knowledge over ignorance. Thank you very much. As the lamp's light continues to radiate throughout the evening, let it remind us of our collective commitment to the knowledge, harmony, and progress that we are resolved together today here onwards. Great. All right, so now we're going to shift the gears and do what we were waiting for. And that is to invite our grand round speaker for tonight. And the person whom we are bringing in today is nothing but less of a legend, Robert Bonow. And Dr. Bonow and my journey has been there. We've met in the meetings, we have spoken through my mentors, and I've got to learn a lot about him. I spent a lot of time today learning from him. But what we have seen is and learned is through one of his mentees, Dr. Kamu Maganti, and Dr. Maganti came and joined us from Northwestern. So I'm going to invite Dr. Maganti to give her first-hand version of what does a leader of Dr. Bonow's stature mean when he walks through cardiology, holding your hands through the clinical corridors. Kamu?
Well, what can I say about Dr. Bonow? I had to think about what I could do, and I'm like, I'm going to forget things. So I actually have multiple pages that I've written down. I'm like, I cannot forget some of the impact that he left on not just me, but a lot of my colleagues and the current fellows. So first of all, welcome to the Combined Cardiology Grand Rounds, titled Progress in Aortic Stenosis, New Insights, New Options, New Challenges, jointly hosted by Rutgers Health and RWJBarnabas Health System. And I would like to thank Dr. Sengupta for giving me this opportunity to talk about Dr. Bonow that I hold very dear. What can I say about him? He's the true epitome of the trifecta that we always talk about. He's a great clinician, he's a great teacher, mentor, and a researcher to the core. But that is not all I could potentially say. Have you ever wondered how different methods and methodologies of viability testing could be utilized? How they are similar yet dissimilar? And why there are differences? This is some of the greatest work that he's ever done within the viability area. And you know why the bowel disease guidelines to a confusion, but also sometimes to make us more confused, keep changing between iterations. And again, he will likely speak more towards that for us. Today, we have the privilege of being in the presence of a true visionary. And he's a leader that he has answered not just the questions that I have posed, but many, many more. In the next few minutes, I will try to summarize not just his CV, but also what I know of him as a man and a few of his accomplishments, just a few out of like the 500 page CV. So Dr. Bonow is a preeminent figure in the field of cardiology with a distinguished career that has been spanning more than 5 decades. He's a native son of New Jersey. He was born in Camden. He graduated magna cum laude from Lehigh University with a BS in chemical engineering. As he felt that wasn't fulfilling what he wanted to do, he actually ended up going to Penn as a medical student. And this actually was phenomenal because that's where he did not only his medical school, but his residency as well. But let me not forget that he was also a co-captain of his basketball team when he was at Lehigh. He was a true Mountain Hawk hero. And I actually think not only was he very cerebral, but that early stage actually led him to understand what teamwork truly means and how he can actually lean on others in addition to leading them. And so leadership came very, very naturally to him. I honestly thought, thank God he didn't go into chemical engineering or biomedical engineering. Not that there is anything wrong with that. I think there is a lot that he has done for the field of cardiology that we would have missed. After he completed his residency in 76, he went to NHLBI in Bethesda, Maryland, where he did another cardiology fellowship, where he was a clinical associate between 76 to 79. During his time at NHLBI, he advanced to senior investigator and then held multiple leadership positions, including chief of nuclear cardiology, deputy chief of cardiology branch, And honestly, I think that's where he was doing a lot of research in aortic regurgitation, and this was MOD. And surprisingly, the MOD research actually led to a lot of guidelines that we have followed over, I guess, many iterations. After he was at NHLBI, I think those years actually shaped Dr. Bonner's unique ability to blend scientific inquiry with clinical expertise, which is a hallmark that you see has defined his entire career. In 1992, Dr. Bonner joined Northwestern University. Dr. Landsberg was the one who recruited him, where he holds the title, currently still holds the title of Max and Lily Goldberg Distinguished Professor of Cardiology. He served as chief of the Division of Cardiology from 92 to 2011, and then vice chairman of the Department of Medicine from 2008 to 2020. I call him my first chief. He hired me, and he holds a very dear position in my heart. During his illustrious tenure, he revolutionized Northwestern's Division of Cardiology. He led it for 2 decades and turned it into a powerhouse of innovation, research, and clinical care. Everything was extremely quality driven while I was there. His leadership extended beyond the walls of Northwestern as co-director of the prestigious Bloom Cardiovascular Institute between the years of 2004 to 2009, where his influence helped establish one of the foremost cardiovascular centers in the world. His passion for education and learning never left him. So in 2012, he was doing homework when he actually pursued a master's degree in healthcare quality and patient safety. But that actually lit a fire in all of us. A lot of us went on to do MSCI thanks to him. His commitment to academic excellence is demonstrated through his mentorship and teaching, which has shaped the careers of numerous cardiologists and researchers. At the annual ACC scientific sessions, we have the Bonow reception, where countless number of people he has trained, he continues to train, and worked with or mentored, we all aggregate to celebrate him and connect with each other. As an attending physician at Northwestern Memorial Hospital since 92, he has provided expert clinical care. And thanks to him, I got to see some celebrities that I cannot name, could not say hello to in the hallways. I would just look at them and think, see you. I can't talk to you, but I see you. He has contributed to numerous clinical trials that have transformed the treatment of valvular heart disease, ischemic heart disease, cardiovascular imaging, and heart failure. His pioneering work in nuclear cardiology and non-invasive imaging has led to significant advancements in diagnosing and managing cardiovascular conditions, especially in patients with valvular heart disease, including a few of the worried well. One of Dr. Bonow's most enduring contributions is his mentorship. He has guided and shaped the careers of countless cardiologists and researchers. Many of them hold leadership positions worldwide. His passion for nurturing the next generation of leaders ensures that his impact will continue to resonate long into the future, driving innovation and excellence in cardiovascular medicine for years to come. The fellows at Northwestern used to fight with each other to cover his clinic or to get into his clinic as his clinic fellows. So it was amazing to watch them all fight over each other. A prolific researcher, Dr. Bonow has published over 650 peer-reviewed articles and has contributed to numerous authoritative textbooks in cardiology. Few have contributed to cardiovascular research with the breadth and the width of Dr. Bonow. His pioneering work has helped shape clinical guidelines and standards of care worldwide. His research continues to influence contemporary medicine, particularly in the management of valvular heart disease, ischemic heart disease, and heart failure. He has been part of developing guidelines for the ACC-AHA, which has set benchmark for cardiovascular treatment across the globe. He's one of the 4 editors of the Braunwald's Heart Disease, the textbook of cardiovascular medicine. The cardiology fellows at Northwestern typically got an autographed textbook whenever they joined. As editor-in-chief of JAMA Cardiology since 2015, Dr. Bonow continues to shape a conversation in cardiovascular research, ensuring that new cutting-edge insights reach clinicians, reach researchers, and also healthcare leaders. His contributions have extended to major national initiatives, not just national, but also international, where he has played pivotal role in translating scientific discovery into tangible healthcare policies and practices that save lives every day. He has served on multiple editorial boards and prestigious journals. His long-standing involvement with American Heart Association and American College of Cardiology includes chairing key committees leading initiatives to establish evidence-based guidelines for us. Dr. Bonow's contributions to medicine have earned him multiple accolades, including the NIH Director's Award in 1986, U.S. Public Health Service Outstanding Service Medal in 91, Eugene Drake Award in 2002, Côte d'Or Award, the Golden Heart Award from AHA, Distinguished National Leadership Award from AHA, Silver Medal Denolin Award from ESC, Women in Cardiology Mentorship Award from AHA. And I was part of the group, and we were so happy to take pictures with him at this function. James Herrick Award from AHA, Master of ACC in 2011, Master of ASNC, Distinguished Scientist Award from ACC in 2019, and these are just naming very few of the multiple awards that he got. His leadership within professional societies, including his presidency of the Society for Heart Valve Disease, underscores his global influence. Throughout his career, he's been invited to serve as a visiting professor countless number of times at multiple leading institutions. And the latest one was at the Mayo Clinic this year. He has held significant leadership positions both at national and international societies. He served in multiple positions in various professional societies such as ABMS, American College of Cardiology, American Heart Association, acted as ACC liaison for director of NHLBI between 2003 to 2006. He was on the board of trustees for ACC, was part of steering committee for COCATS 3, and then part of executive steering committee on FOCUS, which is National Quality Initiative on optimal utilization of cardiovascular imaging. His involvement with governmental committees and contributions to science extend to policy development. He served on the committees for NIH, US FDA, as well as the CMS. He also was part of directing the government of Qatar for some of the healthcare initiatives that they had. So I'm, again, just scratching the surface here. Even after decades of pioneering contributions, Dr. Bonow's work is far from complete. His research continues to break new ground, particularly in the evolving field of cardiovascular imaging, as well as valvular heart disease. His extensive lectureships and keynote speeches address all of this, and his continued passion to share knowledge and address the most pressing cardiovascular challenges of our time. I am going to conclude. Dr. Bonow's career is an embodiment of excellence, innovation, and dedication. His leadership, clinical expertise, extensive mentorship, and groundbreaking research have redefined the field of cardiology. I don't think we have too many others who have done this much of work within our field. He is a physician, educator, thought leader, and his contributions will continue to leave an indelible mark on all of us who work in the cardiovascular field for generations to come. on a personal front, he is a true family man. With his lovely wife, Patricia, by his side, they have raised two wonderful sons. Robert, who is a neurosurgeon, and as Dr. Bonow was mentioning, he is busier than Dr. Bonow currently. And Samuel, who is completing his PT. He is a granddad and has two grandkids. He likes to read, he likes to bike, and he likes to hike. And don't forget, he also is a pretty mean basketball player from what the fellows used to tell us, especially when there were matches between the fellows and the faculty. And a lot of our fellows ended up breaking their toes or bones in their feet. So a lot of accidents did happen. Dr. Bonow, I'm forever grateful to have known you and for all the advice you have given me over my time there, and you continue to give me even now. Thank you again, and I would welcome you to the podium.
Well, thank you so much, Kamu. It's going to be hard to live up to that, I think. But I'd like to thank you and also for Parthos and Gupta for the invitation to come back to New Jersey. I grew up in Westfield, which is exit 135 on the Parkway. I wasn't going to mention the basketball story, but you mentioned it. So I'll say the last time I was at Rutgers, it was probably when I was playing against Rutgers back in the era when you had Bobby Lloyd and Jim Valvano and Bob Friesen, who had their own outstanding basketball careers after those interactions. And although we did play basketball with the fellows, the problem with that is that the fellows never age. They're always the same age. And the faculty get older every year. So we finally decided we would stop doing that. So for the topic for tonight, I thought I would talk about a topic which is growing in interest and intensity on aortic stenosis. And what we've learned over the course, perhaps, of the last couple of decades and into the current era of transcatheter valve technology, only a small piece of that discussion will be transcatheter technology. I have no relation to disclose. Kind of nice to be back in New Jersey again. But I thought I'd start with a little history of my own, and that is I went to school, medical school at Penn. This is the old medical school building there. When I was a third-year medical student, took my cardiology rotation, and the first patient I saw was a patient with aortic stenosis, symptomatic aortic stenosis, 1972. And what does a third-year medical student do when faced with a patient with aortic stenosis? Well, obviously, you go back to your first-year medical student notes. My wife and I downsized our house about 2 or 3 years ago, and I had to clean out my files. And I actually came across this two pages of notes that were, back then we didn't have PowerPoint, we didn't have Xeroxes, we would get these mimeograph sheets that you can see I marked up a little bit. And even back then, as a first-year medical student, I was interested in afterload, preload, Laplace relationship, systolic gradients, and so forth. And so I realized this was part of my upbringing when I was cleaning up my files. But then what struck me was this little note down here. There was only one reference. And this is a reference from Glenn Morrow et al. And I'll tell you who were the co-conspirators of that paper about left ventricular outflow tract obstruction. This came from the National Institutes of Health. And those of you of my era remember that there used to be these clinical staff conferences from the NIH that got published in the Annals of Internal Medicine. And this is what actually got me to where I started to go in terms of aortic valve disease, because this is a kind of a gas house gang of names here that the older generation would recognize. Bill Roberts, John Ross, Dean Mason, Eugene Brownwell. But the ringleader here was Andrew Morrow, who was a surgeon. He had recruited Morrow to come to the NIH. and do the innovative stuff that he did during the course of the 1960s. And so when I read this as a third-year medical student, going back with my patient with aortic stenosis, the little light that went on in my head is, I want to be like them. They were putting papers in the literature about 4 or 5 times a week, in the course of about a decade, really defining what we think we know about the physiology of the heart and its hemodynamics. And so that's what I did. I went to the NIH. I was going to do 2 years. I actually wound up spending 16 because of the exhilaration one gets being surrounded by research enterprise, and of course your tax dollars paid for my research. So let's just talk about what I did and where we went from there. So when I was training, we thought that this valve stenosis, heavily calcified valve, was kind of a passive result of wear and tear, kind of like a rusty gate left out in the rain. But we've learned a lot more since then. For example, these are data from the Canhart study in Ontario, where they have data on every citizen in Ontario. And they have 1.1 million individuals in Ontario over the age of 65, with a median follow-up of 13 years, 20,000 plus of whom developed aortic stenosis. And what they found was that the standard cardiovascular risk factors, hypertension, diabetes, dyslipidemia, were significantly associated with the subsequent development of aortic stenosis, kind of replicating what had been found earlier in the Framingham offspring study. And so risk factors are important and suggest that perhaps this is not just a passive phenomenon, but perhaps a process of active inflammation, proliferation, and calcification. That's been verified now. And so I'll just show a couple pieces of evidence for that. This comes from Mark Dweck's group at the University of Edinburgh, in which they've done a PET CT study. The CT, obviously, to define the calcification in the valve, but the PET study was done to do 2 things. It was done to look for microcalcification with sodium fluoride, and also look for inflammation with F18 fluorodeoxyglucose. So here's 3 examples they have of the normal valves, mild aortic stenosis, and severe aortic stenosis. So the severe aortic stenosis is associated with an active process of inflammation and calcification. More importantly, this group came back subsequently with a serial follow-up of a series of patients in that group. So here's 2 patients in that group studied at time 0, where there's a little bit of calcification. You can see on the left, a lot of inflammation shown on the fluorodeoxyglucose scan. And when these 2 patients were followed up, those areas of active inflammation turned into severe calcification over the course of time. Further evidence for this comes from numerous studies, including this one from Mahmoud and co-workers, where valves excised at the time of aortic valve surgery were examined and found to have a upregulation of lipoprotein-associated phospholipase A2. That's an enzyme that cleaves phospholipids into fatty acids and phosphatidylcholine. Phosphatidylcholine being an inflammatory mediator. And so here you see in these excised valves, upregulation of the enzyme on the left associated with oxidized phospholipids. And just to wrap that part of the story up, there's also some genetic predeterminants as well. This is a large GWAS study from George Stanislawis involving initially 4,600 individuals of multiple ethnicities, with a replication to verify these results in 45,000 individuals of multi-ancestries across the world. And what they found in this GWAS study was a single SNP sitting on chromosome 6 in the locus of LPA, which is the gene that codes for circulating levels of LP(a). So LP(a), if you've been following this story, has gotten a little bit of energy as perhaps one of the mediators for development of and progression of aortic stenosis. This was verified by a study from Denmark by Kanstrup and co-workers, where we're looking on the left of levels of LP(a), and on the right, the risk of developing aortic stenosis on the right using a multivariable analysis. So that the higher levels of Lp(a), the higher the likelihood of developing aortic stenosis with time. But importantly, they also had genomic data in these individuals. And the individuals who had the higher levels of Lp(a), more likely to develop aortic stenosis, also had roughly 50 to 60% of them were carrying that single SNP in chromosome 6 related to the abnormalities related to elevated Lp(a). So the scenario might be something like this, borrowing this from Billy Peeborough. Lp(a) gets into the intracellular space, gets hydrolyzed by the enzyme we talked about, phospholipase A2, into oxidized fatty acids and lysophosphatidylcholine, an inflammatory marker, in addition to which the oxidized phospholipids and the phosphatidylcholine attract macrophages, creating an inflammatory milieu, which over the course of multiple intricate steps, which are too simplified here, including things like bone morphologic protein and NF-kappa B, TNF alpha, can lead to mineralization. This is much too simple, but I don't want to make it too complicated, because to make it more complicated, we're kind of looking at the New York subway map here of all the various pathways that could occur. And thus far, I've only been talking about lipid infiltration on the left. What also occurs is inflammation and fibrocalcific responses. And the important point here for the younger members of the audience is that these are all potential druggable targets. And in your future, you are likely to see some drugs in the pipeline, not just those that can inhibit Lp(a), but others in these multiple pathways that could slow down the process. And indeed, what we're talking about so far has been too simple. Aaron Small went to the Million Vets program and published a manuscript involving 4,500 individuals from the Million Vets program who had aortic stenosis, compared to 400,000 individuals who did not have aortic stenosis. And they identified not a single SNP, but 14 important SNPs that were kind of interesting, because it was not only looking at lipid metabolism, but also calcification, adiposity, cellular senescence, and multiple other things here that could be, again, druggable targets related to the genetic profile of these individuals. That then led to attempts to come up with polygenic risk scores, thousands and thousands of individuals on the left from the the Million Vets program, UK Biobank, 6 TIMI trials of 400,000 individuals with a polygenic risk score. And then also there have been large-scale proteomics identifying novel biomarkers, things like metalloproteinases, GDF15, other biomarkers related to inflammation and proliferation. Okay, so there's a story here, again, with the ending. We hope that sooner or later there may be a way of slowing down this process of severe valve calcification. But let's not stop there, because we should also be talking about what that valve does to the left ventricle. It creates left ventricular hypertrophy. It's a marker of the pressure, of the severity of the pressure overload. It's a compensatory mechanism to reduce the wall stress in the setting of pressure overload. But like any other compensatory mechanism, it's a good short-term fix, but it has long-term, perhaps adverse consequences related to that left ventricular hypertrophy, because that can be a contributor to myocardial stiffness and increased left ventricular end diastolic and left atrial pressures, and therefore symptoms of HFpEF, symptoms despite normal left ventricular ejection fraction, and that could be a contributor to adverse outcomes. Now, how could we study what those effects might be? Back in my early days in the 1980s, I was aware of colleagues in Zurich, Switzerland, Otto Hess, Hans-Peter Krembühl, who were doing left ventricular myocardial biopsies in patients before and after surgery. And what they found was, what you suspect, that once you have cross-linked collagen, that tends to be pretty permanent. When you replace the aortic valve, the hypertrophy regresses, meaning the myocyte volume is reduced, but the collagen stays the same. So you have an increase in the relative ratio of collagen versus myocytes. i.e. more left ventricular stiffness. So you solve the problem by replacing the valve, but maybe you waited too late because now you've got some patients who are maybe at risk for left ventricular stiffness and HFpEF over the course of time, not to mention the fact that the fibrosis could also lead to ventricular arrhythmias. Well, we don't do biopsies anymore. Instead, we can do this with MRI. And harken back again to the work of Mark Dweck, although others have replicated these findings. As you all know, one can assess left ventricular myocardial fibrosis looking for late gadolinium enhancement with magnetic resonance imaging. A whole series of papers came out of this work and others, but the one which was most fascinating to me was when Chin and co-workers working with Dweck and the team in Edinburgh had a series of patients with aortic stenosis. They were all symptomatic, all being studied before surgery. So this is not necessarily pertaining to asymptomatic individuals, but they had three groups. Those who had normal MRI studies on the left, those who had replacement fibrosis, scar tissue on the right, and in the middle, an increase in extracellular volume based upon T1 mapping. And so when they looked at these three groups, as expected, there was kind of a continuum here of more severe aortic stenosis, so the aortic peak velocity increases sequentially. There's more left ventricular mass, as you'd expect as well, increasing sequentially. That leads to left ventricular diastolic dysfunction, increasing the time and severity. And what was most interesting to me, there were also troponin leaks. So there was elevated troponin in the patients who had the replacement fibrosis. You know, okay, that's what we're seeing. The scar tissue is the effect of myocyte damage and replacement fibrosis. And so one could then start creating a scenario of what the left ventricle is going through with aortic stenosis. You have hypertrophy and diastolic dysfunction. That leads, the hypertrophy also creates interstitial and replacement myocardial fibrosis, which makes the diastolic dysfunction worse. And then perhaps there's microvascular disease also related to the hypertrophy, can lead to myocardial ischemia, and that's going to feed back to both the replacement fibrosis, and the ischemia could also contribute to diastolic dysfunction. So those are the things to keep in mind, that if we're talking about therapies to treat the valve, slow down progression of calcification of the aortic valve, how about therapies to modify the left ventricular response to that in a way that might be safe to reduce the amount of either ischemia or fibrosis or both? A nice summary by Brian Lindman and Joanne Lindenfeld. Treat the valve, treat the ventricle. So these thoughts are out there. They're not necessarily novel, though we have novel methods to study them. And a nice summary of this comes from the work of Catherine Otto, and it's hard to imagine this is actually now 10 years old, because when it was first published, I said it was must reading for our fellows, and it probably still is must reading for the fellows. It's talking about how the normal valve progresses, calcifies, how one can determine that, study that, what are the indications for surgery. Now, the must reading for me, when I was a fellow, was this paper from 1968 from Ross and Brownwall. You've all seen this paper, whether you recognize it yet or not, because this is a paper talking about the grave prognosis that appears to accompany the onset of certain symptoms. And this is the paper where the very famous cartoon shows up from Ross and Brownwall, talking about the natural history of aortic stenosis over the course of time, progressive stenosis, progressive myocardial overload with a compensated state until patients develop symptoms. When they develop symptoms, it's a rapidly progressive and predictable condition with poor outcome. And over the course of the next 3 to 5 years, 50% of the patients will die. So has anybody noticed how this figure is kind of interesting? Number one, where are the patients? There's no patients here. There's a concept. And if you actually read the paper, you'll see the concept is based on their observation in 12 patients. Okay. And so this was published in 1968. In 2018, we had the 50th anniversary of this figure. We actually had a little ceremony for Dr. Brownwald at the Heart Valve Society meeting in New York. And I kind of kidded Dr. Brownwald by saying something to the akin that, Gene, you know, you had these TIMI trials, 30,000 patients, 40,000 patients. I doubt that any figure in these TIMI trials is going to have the lifespan that this figure has based upon those 12 patients. It's a concept of, bright individuals thinking about what could be going on. And of course, in the current era, this curve shifts to the right. Back then, they were talking about, rheumatic disease and bicuspid valves. Now, with an aging population, the same phenomenon happens, or what happens at a later age. And the other remarkable thing about this figure is that it's accurate, because in real patient data, if we have patients with symptomatic aortic stenosis who do not get intervened upon, one finds that just as predicted by Ross and Brownwald 40 years before this paper was published from Michigan, 50% of the patients have died over the course of the next 3 years, exactly as predicted. Dr. Brownwald did indicate to me off the cuff later in private that actually was drawn on the back of the napkin. So they sat in Dr. Ross's kitchen one night and tried to figure out, and the reason they had to figure it out was, again, Dr. Morrow, the surgeon. So the surgeon was telling these cardiologists, what are you doing? You're either sending me these patients too early or too late. What's going on with these patients? And so it was a surgeon who forced them to huddle in the kitchen and come up with a diagram on a napkin. Okay, so that's kind of easy. We've got a patient who's got symptomatic aortic stenosis, the class 1 indication in the guidelines to recommend valve replacement. There's never going to be a clinical trial to randomize patients, but that's what we got. So it's not a class 1A, if you would. But that's easy to write a guideline. And it's easy for the fellows to take a board exam and realize you're going to replace the valve in a patient with symptomatic aortic stenosis. But how easy is that in practice? You're dealing with patients like I see who are deconditioned, sometimes overweight, not exercising, and they're a little short of breath. Okay, is symptomatic aortic stenosis, or is that a symptomatic lifestyle issue? It's kind of messy stuff, because we really don't have ways of determining what symptoms really are in these patients. And even more difficult is trying to figure out the asymptomatic patients. Because again, patients who are starting to get a little short of breath stop doing things. And so they downgrade their activity level in order to not have symptoms. And so what do we do with patients who are claimed to be asymptomatic? Are they really asymptomatic? Well, let's go to the guidelines. The guidelines say, let's do exercise stress testing, both in the US and in Europe. And if the patients have a decrease in blood pressure, it's a class 2A. If they have poor exercise tolerance, it's class 2A. Symptoms, it's a class 1, because you unmask the symptoms in a patient who claim to be asymptomatic. But even that's not easy. I mean, again, if you're dealing with a deconditioned individual, perhaps with lung disease or arthritis, and that patient goes 1 minute on the Bruce protocol, is that a cardiac limitation, or is that the lifestyle limitation? So it's helpful, and we do it, but it's not perfect in determining who is truly asymptomatic. You have to consider age, sex, comorbid conditions, and overall level of fitness. And that's why it's not so easy. Easy to write the guideline, but very difficult to implement in practice. But we do know that if we have a patient who's got asymptomatic severe aortic stenosis, defined as a peak velocity across the aortic valve of 4 meters per second, numerous natural history studies indicate that over the course of the next 3 to 5 years, the vast majority of them will have an endpoint. The endpoint here is not usually death. The endpoint usually is development of symptoms requiring aortic valve replacement. The point there being, what do you gain in waiting if you've got a patient who's got severe aortic stenosis? The likelihood that the person would need aortic valve replacement, even if asymptomatic, over the course of the next 3 to 5 years, is pretty high. So it's never wrong to kind of jump the gun and consider intervening on patients when they start developing severe aortic stenosis. But this early AVR in these patients actually lead to improved survival. And this got debated for years, but now we have 2 clinical trials you're probably aware of. Kang and co-workers, a recovery trial from Korea, and Bonow and co-workers from the Avatar trial in Eastern Europe. These were 2 good clinical trials, but they were small. About 150 patients each, severe aortic stenosis, as you can see. In Korea, very severe with a Vmax of 5.1. But on the right, where we have the European trial, these patients were really asymptomatic because they could be put on a treadmill and get to 85% of maximum predicted heart rate without symptoms. So they're asymptomatic patients. And what were the outcomes? The outcomes in these randomized groups showed that the survival on the left from Korea was significantly reduced, significantly improved with surgery, and worse outcomes in the patients who were managed conservatively. But that trial did have a ability to cross over. Patients had symptoms, they could then go to surgery. So my concern with this trial is that there's a 26% mortality over the course of 8 years in these patients. So who's minding the farm here? Who's following these patients? Perhaps they were being entered in the trial, but they're not followed up carefully enough to actually intervene when needed. So that's my concern about the recovery trial. The trial on the right by Barnabas and co-workers was underpowered because they were supposed to have enrolled 310 patients and only enrolled 157 because it was stopped prematurely during September 2022 in the middle of the COVID epidemic. So they probably had trouble enrolling patients. They did find that a combined endpoint of death or heart failure was reduced with surgery. It was significant, but when they looked at mortality, there was no difference in outcome. The other issue here is that 85% of the patients in this multi-center trial from Europe were enrolled in one single center. So you get worried about a multi-center study where most of the patients are coming from the lead author in the paper. Well, my fears on the right study on the right were reduced greatly a couple of weeks ago when they published the 5-year outcomes of the AVATAR trial. And they found that the curves continue to diverge over the course of time with the benefit of early surgery. And now they also found at the top a reduction in mortality, as well as a reduction in heart failure admissions in the patients who got the early surgery. So this was kind of a lasting effect, which now with 5 years follow-up was significant. So I'm more of a believer in that trial. But what do I do now based upon what we've discussed so far? I've got an 84-year-old man, got severe aortic stenosis. Let's give him a Vmax of 4.5 and a mean gradient of 48 millimeters of mercury. Okay, severe aortic stenosis, claims to be asymptomatic. We could do watchful waiting. We could get more data, maybe a stress test, maybe a BNP, or if we just replace the valve at this point. Neither of those three options would be incorrect necessarily. They might be correct. But watchful waiting now has a nice different connotation for the younger people in the audience than it did when I was training. Watchful waiting means now let's wait till he develops symptoms, because he will over the course of the next 3 to 5 years, as we discussed, and that makes him a candidate for TAVR. And that's what he wants. He wants to wait until he can have a TAVR. He does not want to have open heart surgery, and yet the indications, are that we do not yet have an indication for asymptomatic individuals. Now we could put him on a treadmill, make him short of breath, and okay, then we got enough to do a TAVR. But what I did was I enrolled him in a clinical trial. And we have 2 clinical trials that will be released a month from now at TCT that may give us the answer. The early TAVR trial is randomizing asymptomatic patients with severe aortic stenosis to TAVR now versus TAVR later. And the EVOLVE trial, coming from Mark Dweck in Edinburgh, is looking at patients who have that kind of MRI signal of left ventricular hypertrophy and extracellular volume increase and fibrosis, and randomizing them to early TAVR versus not. So we'll have some answers perhaps just in a month from now that might solve the issue here. So that's just one challenge we're dealing with. The asymptomatic patient with severe aortic stenosis. How about the patients with low flow, low gradient severe aortic stenosis, which happens to all of us, unfortunately, all the time. It could be a patient who's got left ventricular systolic dysfunction because of the severe pressure overload, depressing left ventricular function, afterload mismatch, if you will. Here we use a dobutamine echo or dobutamine hemodynamic study in the cath lab to see if the patient has a augmentation of flow with dobutamine to give us more of a true signal as to whether this is true aortic stenosis, in which case the patient's a candidate for either surgical or transcatheter valve replacement, or the patient may have a primary cardiomyopathy, where the patient's a candidate for guideline-directed medical therapy. But there's also a trial for that. Patients who have a primary cardiomyopathy, only mild to moderate aortic stenosis, undergoing TAVR in the TAVR Unload trial. You could argue that if the patient has a primary cardiomyopathy, perhaps even moderate aortic stenosis could be too much pressure overload for that sick ventricle. And maybe TAVR would be the answer. These patients are, as you know, difficult to manage. Dopamine echo is not necessarily a risk-free test for patients, but at least we can understand the physiology about what's going on with these patients. What's more difficult are all the patients you and I see who have low flow, low gradient, normal left ventricular function, paradoxical low flow aortic stenosis. And this is about 40% of the patients we see now with aortic stenosis. Really tricky stuff. So this diagram suggests why that could happen. You've got severe hypertrophy, perhaps what you see with women, where you have a small left ventricular cavity. Even though ejection fraction is normal, the stroke volume is reduced because of the low end diastolic volume. The patient may be hypertensive, giving you an extra impediment to outflow. And so we treat the hypertension. You may have had this experience. Treat the hypertension and then restudy the patient. Now you have a more normal flow pattern. Patients should not only be studied by echo, but also by cardiac catheterization. And does the patient have valve calcification or other indices that suggest aortic stenosis with some of our advanced imaging techniques? But if the valve's not calcified, it's probably not severe aortic stenosis. Quick point about that. You know, men and women have different levels of what is considered severe calcification of the aortic valve. Men have more calcification than women, meaning women have more of a fibrotic process across the board compared to most men who have a lot of calcification. What's really important here is that we have a clinical skill set. Does this look and smell like it could be a patient with aortic stenosis, and is aortic valve replacement going to make a difference? This used to be underdiagnosed. I know I lost a couple patients 2 decades ago, but I couldn't believe it was true aortic stenosis because the patient didn't have gradient with a normal ejection fraction. And so I think I made a mistake years ago. But now, since this is published almost every week in our cardiology journals, I think we tend to have a tendency to overdiagnose this condition. And so perhaps we consider other conditions that could create the same phenotype, like amyloidosis. Okay, so the key knowledge gaps, the symptomatic patient, cardiac symptoms, asymptomatic patient, really asymptomatic. What are the mechanisms of inflammation and calcification? What's the role of biomarkers? How do we handle the patients with low flow, low gradient aortic stenosis? And then what are we going to do with the evolution of TAVR to low risk patients? So that's clinical challenge number 3, TAVR versus TAVI. As you know, I mean, this is really taken off appropriately. And this is data from the STS database up to 2019. And what's interesting is initially TAVR was taking off because these patients were not operative candidates. There was no change in surgical volume in orange and red. But with the advent of the low risk trials, then TAVR really took off, and now you see a decline in surgical volume. The surgical volume now is usually for patients who also need concomitant bypass operations, mitral valve replacement, or maybe they're younger individuals. Because the guidelines have certain criteria for whether you should consider surgical versus transcatheter valve replacement for severe aortic stenosis. Most important is shared decision-making with you and patient involving, this multidisciplinary heart team, cardiologists, surgeons, nurses, social workers coming together to help make decisions with the patient. But we recommend SAVR surgical for patients less than 65, TAVR for patients over the age of 65. But TAVR is equivalent to SAVR in patients between 65 and 80. There was a shared decision-making. Of course, most patients will opt for having TAVR. But this is the thing that we have to keep an eye on. What's happening in our younger individuals who are getting valve replacement or under the age of 65? You may be aware of some database issues which have shown that in this study from Sharma and co-workers, this is a look at academic medical centers in the United States. So the academic medical centers where presumably people have read the guidelines, and looking at the increase on the left of patients under the age of 65 undergoing aortic valve replacement, where now 50% of the patients in academic medical centers get TAVR. Okay, this is not unique. There's also a study from New England, 4 medical centers in New England, looking at temporal trends in transcatheter valve replacement. Again, on the left are the individuals less than age 65. And by 2022, as you can see here, again, half the patients are getting TAVR, not surgical. That has some indications for younger individuals because we still have some issues regarding durability of a transcatheter valve. Is there going to be a need for repeat procedures? And also the higher risk of pacemakers in individuals who undergo transcatheter versus surgical valve replacement, which may be okay for an 85 or 90-year-old, but not a good thing for a 55-year-old. So that gets into then this whole issue that you've been hearing about, and I'll be talking about, is lifetime management of patients with aortic stenosis. A patient of any age gets a TAVI, but what happens when that valve begins to have structural valve deterioration? You do another TAVI, and what do we do when that valve deteriorates too? So if you're starting out with a 40 or 50-year-old, you're likely to have this scenario where you may need, over the course of a lifetime, 2 extra interventions. Or it could be TAVI followed by surgical AVR, second time around, and then TAVI to follow that. Surgeon will tell you that's kind of a messy procedure when you're trying to explant a transcatheter valve into a bed of calcium. How about the patients who have surgical AVR at young age? They're also destined to have some issues. Do we do TAVI the next time and TAVI the time after that? Or do we do a surgical valve again? So these are the kinds of SAVR, TAVI. I mean, all the ways that you can mincemeat the possibilities, but it's complex, especially when we talk about interventions in young people. And so the challenge is the threshold for TAVI is declining in clinical trial registries and clinical practice. The evidence of an indication creep. I think the multidisciplinary heart team is essential. It certainly worked in our institution, getting the surgeons and cardiologists talking the same language and including the patients in the discussion. Shared decision making, again, keeping the patients in the discussion. So the real issues for us right now are all patients want this, and they need to have a valve replacement, and determining when to withhold TAVI is becoming more and more difficult. I'm sure you have those discussions with your patients. They all want TAVI, but maybe they're 40 years old with a bicuspid valve. Or maybe they're 96 years old with so many comorbidities that even replacing the valve is not going to improve the quality or longevity of life. And so that leads to the final thing. Okay, so where are we going with all of this? Well, my institution has been part of all of these clinical trials, starting with prohibitive surgical risk, going up to low surgical risk. In a month now, in 4 weeks, we're going to get some data on asymptomatic patients, early TAVR trial, the EVOLVE trial. There's also a trial in patients who have low ejection fraction with moderate AS that we talked about, TAVR on low trial. And there's also a study going on in patients who have normal ejection fractions with moderate AS too, the PROGRESS trial. So any of these trials being positive, it's going to change everything we do in patients with aortic stenosis. It's going to just totally change everything. And so that's going to happen in the next month or so. So where we're really going is we have new TAVR devices for aortic regurgitation in trials, medical therapies to slow progression of aortic valve disease, where you treat the valve and treat the ventricle, greater precision in selecting patients for intervention, advanced imaging, biomarkers. And then Partho, I had this in here even before I had the conversation with you. This is Holst in Newcastle. How about artificial intelligence to aid in the timing of the intervention based upon the patient characteristics, aid in the device development itself, and to achieve greater precision in matching patient and device. And if you've been following the literature, there's a lot going on, including work from Partho and his colleagues here and also at West Virginia. And there's interesting stuff here about how using either imaging or even ECGs to identify who has aortic stenosis and maybe who is likely to progress over the course of time. It's kind of interesting. I can't get into this in any more detail than just showing you what I see out there, having read these papers. Partho is a maven to tell you exactly how to interpret the black box of artificial intelligence, which I really cannot do. But they're interesting studies, not only showing who is likely to have aortic stenosis, but who's likely to have progression of aortic stenosis over the course of time. So to wrap up, I'm going to just end with one slide from Paul Wood, Again, you have to be an oldster like myself to remember who Paul Wood was. He was the preeminent London cardiologist of his era. He has a wonderful way of talking and writing. So if you read this paper, it's masterful English. So it's kind of worth a read. 1958. This was what, 65 years ago or so, if my math is correct. And so Dr. Wood has very pithy comments. Aortic stenosis is a simple mechanical fault which, if severe enough, imposes a heavy burden on the left ventricle and sooner or later overcomes it. That's pretty well said. Except for you and me, it's not simple anymore. This is really complex thinking, complex interactions with our patients, trying to time procedures to be done correctly and at the right time and at low risk. And it creates challenges for all of us. That's why it's kind of interesting, kind of fun to still be in this field, because it keeps evolving. But it's not simple anymore. So I'd like to thank you again for coming and the opportunity to come back to New Jersey. Thank you, Partho and Kamu. And hopefully, there's been of some interest to you, and happy to answer any questions. Thank you. Maybe I'll just start by asking our journey of your stenosis. Yeah, and it was great to see what your group is doing and see what Naveen is doing in the patient lab. It was a fascinating visit to the lab earlier today. We are, I would say, all coming together. Why? Because aortic stenosis, as you're mentioning, complex, and patients get referred idea of the different things that go in that process to parse the process so that the right thing happen. How would you, given the state that are, how would you design aortic valve screening in the community to a tertiary care? Yeah, well, screening is interesting. We talk about screening. That's another whole issue, is how good are the general practitioners at listening to hearts and noticing a murmur and then moving with it appropriately. So that's the screening issue is really, I think, really important. Maybe EKGs to identify who could be at risk could be a way of doing screening also. But once we have a patient who's got maybe not just mild aortic stenosis, which every cardiologist sees. When the patient starts progressing, I see a lot of patients, but I do feed the heart team with these patients. Let's get some other heads involved in the decision-making. And I have a couple of patients where let's just do the CT TAVR now, even though the patient's not a candidate yet for TAVR, because when the patient needs a valve replacement, we already have the CT TAVR in our hands, and we know whether the patient's a candidate, but that allows us to have the discussion with the patient. But I think for me, it's kind of helpful that we have a heart team, because I can get the surgeons and the cardiologists talking with me and the patient about what our next steps could be. Usually I refer patients in when I think they're already a candidate for a valve replacement, and I think they should have a TAVR, so it's kind of an easy discussion. But then it's easy because the nurses get involved. The nurses schedule a lot of the testing. They schedule the appointments with the cardiologist and the surgeon, and also schedule the time with the cardiologist and the surgeon to talk together, which is kind of what CMS wants us to do. We're going to get reimbursed for TAVR. And so I think it's easy. So I have a couple of go-to people in our heart team. I send them a text message saying, I don't think you see Mr. So-and-so or Mrs. So-and-so because I think she's a candidate for valve replacement and I'm in favor of TAVR. But just like the Mass General Brigham data, I mean, a lot of the patients do not get diagnosed for a very long period of time. Yeah. Even in the best scenarios. It's very challenging, I would say. I mean, even for experts, we can keep on probably sitting on an hour and not. Aspect is when you talk about heart team, what does it mean? In the sense, like, should we be in a room together? Aspect of our heart team, we talk about it. Yeah, be together, but yeah, particularly when you have community and third.
as good as any other center, but how would you construct that?
Well, that's a challenge. So again, I have it easy in a hybrid tower where we all report to the dean, or the CEO of the hospital, and we're all full-time members of that group. So I have it easy. In the real world, it could be much more complicated. But with the way we do it is we have a meeting every week where the team comes together in person, a surgeon and a cardiologist together, discuss the patients. The patient may actually see a cardiologist or a surgeon asynchronously, but at least they are seen by both, sometimes in the same sitting. But I can see the challenge when you have multiple sites that may be referring patients in, especially if some of those sites also have interventional cardiologists who are experienced in the procedure itself. I still think it's a good idea just to test the waters, but the field's moving very rapidly. I remember when we first did a PCI, a anal balloon angioplasty, we filled the cath lab with all kinds of people who were really interested and held their breath as we blew up the balloon, because it's such a novel thing. And now PCI is done, with one person and a radiology person and a nurse. It's no longer a big deal. And TAVR is kind of moving in that direction too. And so is there going to be some point in time where a obviously straightforward decision for TAVR, 85-year-old symptomatic aortic stenosis, normal ejection fraction, big gradient, short of breath, do we need to go through the whole thing? Well, maybe you do in some cases, because we also have social workers involved, making sure the patients understand what they're going to be getting into and how we're going to follow them afterwards, because our team also schedules the follow-up appointments on schedule as well. But I can see, it could be that in some settings, maybe you don't need a heart team for all the patients. I still think it's, but maybe not for all the patients. But when you have complex patients, I think the point we made with the fellows earlier today, nothing wrong with communicating with colleagues and bouncing ideas off of them as to this decision making, which may be complex, and they're having other individuals involved who can be providing advice on next steps, and sick and complicated patients could be helped.
I had a question about captain score. How you use the captain score in your practice? I've been doing
Yeah.
Traditionally, they have applied this fit cutoff 1,200, 2,000, but then there was a paper out. That's not accurate. We didn't actually diagnose severe AS. In a lot of patients, the captain score is not diagnostic. And then progress study, we recruited patients for the progress trial. The cutoff in progress study was a moderate AS study. Cutoff was 1,200 and 2,000, same what you apply for severe AS. The estimate area was less than 1 centimeter squared. I feel like there's still, especially normally female patients who have maybe some component of back. You don't know where the symptoms are coming from, and captain score sometimes is high, it's not high. I'm not really sure if it's discriminating the right patient.
I agree with you. So if you look at the data from Flavel, I think, and Pibro, who published the first data on valve calcification, which then got, replicated, had a story of its own. It was great. There are a lot of scatter, in those patients who did and did not have severe aortic stenosis. So the mean data and the standard deviations were significant, but there's a lot of scatter between the two groups. So I use it really qualitatively. Is a valve calcified or not? That's going to help me. Okay, this is probably real aortic valve disease. And then what else do we know about this patient that could suggest that it's severe or not? And that's also a Pandora's box, because you have a patient who's got, a high velocity, but a low mean grading, or vice versa. And the aortic valve area, what's so magic about an aortic valve area of 1? The aortic valve area probably should be 0.8. We're talking about severe aortic stenosis. There's a whole story behind that one, which we don't have to get into, is what a guidelines committee does. You had one person in the committee who forced it to be 1. Seriously. And everybody said, no, 0.8. No, 1. And so he got the vote. And so, these numbers are all things. The idea is to put everything together you can, and maybe Partho can help us too, down the road here by saying, okay, let's have a well done machine learned computer algorithm. That will also help us, in these patients as well. That might be another way of doing it, is to let's get some extra advice from what we can do with artificial intelligence. I don't think we're there yet, although Partho may have other feelings about that. That's why I said it's not simple anymore. It's pretty complicated.
Bonow, thank you for sharing a picture of Penn Medical School. I too am a graduate of Penn Med, also a few decades after you, but it was near and dear to my heart. So thank you for that. As a heart failure cardiologist, I'm really interested, and I may be putting you on the spot a little bit, to think, what do you think will be the result of the TAVR on low trial? Because it kind of makes empiric sense in some ways, there's ventricular valvular coupling, and what might happen if you intervene on somebody with moderate AS. They have, HFrEF, but I'm curious to know.
Well, I think the simple answer would be, if that trial's positive, it's going to take away all of this mist, if you would, and about these patients with low flow gradient and low ejection fractions. Because if that trial's positive, okay, that's enough. We don't have to go into this whole song and dance about whether this is truly aortic stenosis or not. We got a patient with low ejection fraction and at least moderate aortic stenosis, and if that trial is positive, maybe that patient should have a TAVR. But we have to wait and see, if those results are not out yet. Can I give a shout out to Jules Garden, who's I see in the audience here? We walked the halls of the NIH back in the 1970s with Walter Henry.
Two questions. One, molecular factor related, the other, they are related. So phospholipids to mechanism. Are there any nuance, not just genetic, but epigenetic, acquired through lifestyle and other related choices would actually change?
Yeah, that's great. That's a great question. So what you could have the abnormal gene variant that puts you at risk, and then other factors, like, in fact, some of the other genes that were found in that larger GWAS study more recently picked up adiposity, as a gene that was also related to cellular senescence, calcification. So there's other things here besides Lp(a), but yeah, there could be other things which are unleashing that genetic mechanism through epigenetic mechanisms or lifestyle or both.
In my previous life, cardiology, but unrelated to coining the term of ferroptosis. Like this A2 mechanism of oxidizing the cardiolipin and or senescence, other types of things. So cardiolipin the division have the majority, yes, but do you actually see that inflammation leading to oxidative stress and fluid?
Well, I can't say that I see it, but I think I believe in it. That is the initially an inflammatory response related to perhaps risk factors, other things. But yeah, I believe the PET data with FDG showing an inflammatory response, not only in those with aortic stenosis, but those who then progress to develop more calcification. So yeah, I think there's an inflammatory response. Now you can argue, okay, the cart and the horse here, is there other things that could have initiated the inflammatory response? It's probably related to things getting into the interstitium, which could be lipids, inciting an inflammatory response. And we're all aware of the fact that the statin trials were negative, but all the statin trials included patients who already had a calcification and some degree of aortic stenosis, so the horse may have been out of the barn. A more perfect trial would be taking patients who have bicuspid valves at age 20 with no stenosis, delicate leaflets, and randomizing them to a statin and seeing who develops calcification or not, because maybe at that stage, LDL lowering might be, LDL cholesterol lowering may be beneficial, but no one's going to fund the trial. No one's going to wait 30 years to see what happens, so it's not going to happen.
My last question is related to AI. I know that, AI is this new thing and data is so poor to get heterogeneity in defining the disease and identifying that it's humans. Should, as an AI scientist, I should rely on the data that comes out of the hospital. What is the real disease burden if you have to? Are they diagnostic regarding?
Yeah, that gets back to this issue of screening. The second question kind of gets back to the issue of screening. And, it's hard to know who's maybe at risk because maybe we're all at risk with the wrong risk factors. So we should be treating risk factors like we would treat other things. I didn't point out that that large GWAS study also showed that there were some genes that were both associated with aortic stenosis and coronary disease, but there were also many others that showed no pleiotropy, no shared risk with one or the other. So there are indeed some genes that are really associated with aortic stenosis alone, unrelated to atherosclerosis. So yeah, how do we prevent this in the community? I think we wait and see for the right drugs to be effective, and meanwhile we could treat the usual risk factors, hoping that they make a difference. So we have no data that they actually do. And then the first question was whether we trust aortic artificial intelligence. If that's safe to rephrase it that way. Yeah. So again, I'm not the expert that you two are here about artificial intelligence, and I think my concern is, okay, we have to have really good data. We've got to replicate it beyond and show that this is generalizable, in multiple patient groups, and that we then data not only on diagnosis but also on outcomes. And I think it's going to be a helpful tool as opposed to a crutch, but I need both of you to tell me whether we're getting close to being there yet.
A quick question and then one comment. And the question is, it's been shown that echocardiography is most widely applied. Echo tends to
Yeah, I think especially if you have other things besides the valve area to suggest that there could be an issue here. My concern is a lot of echo reports come back saying this could be low flow of gradient aortic stenosis because the valve area is low, but there's no gradient and there's no velocity. And as you know better than I do, there's so many assumptions that go into calculating the valve area. You have to assume that the LV alpha tract is circular, which it's not. Where are you placing the sample volume to measure the velocity below the valve? Are you getting a true, accurate profile of the peak velocity itself, which could be eccentric? So there's, I think, some issues with echo. And then there's the other issue with echo that I'm a little uncomfortable to state, but I think it doesn't really pertain to Rutgers, or maybe Northwestern, is that what's the quality of echocardiograms nationwide and in the echocardiographic interpretation nationwide? Because I'm sure you've all had patients referred to you with severe aortic stenosis, which you thought was not severe, or patients who we should have diagnosed years ago because they got severe aortic stenosis and the echo suggested that it was not. So there's those kind of issues with echo. That's why having other techniques available. MRI is really good for measuring valve gradients, as is, and you can also measure the area itself with CT. And then with CT, you also get the calcification.
I can't rely on my physical exam findings. Have you been noticing that?
Oh, yeah.
How do
Oh, yeah.
we, how do we younger fellows about how they should be examining these subset?
Yeah, well, I agree with that because a lot of times the murmur is not very impressive, and in older age groups, the carotid pulses could be misleading as well. But I think we need to bring out all of our physical findings that we can in terms of the auscultation and palpation of the carotid. Yeah, and that's, as we know, a dying art. Um, um, what's helpful for me is serially following the patients. And it's much more difficult when the patient parachutes in at a certain period of time, which may be time for valve replacement or not. But if I'm serially following the patient and questioning, how the patient's feeling and so forth, and whether there's been a change in lifestyle, and is the echo moving in a certain direction along with the changes in the lifestyle, I think that's what's most helpful. But I realize the issue, especially that we've been talking about, in the community, how good are the GPs at doing all of that.
And the idea of the language of it. A question in regards to, mentioned the comment that you talk about Saturn and then cavern inside Saturn, cavern and the cavern to cavern, how long are you going to go on? What's that end of it? So, so what are your thoughts about it? Do you think at some point in time, or maybe it's already going on, I'm not aware, of developing valves that are hard biopathetic, hard mechanical, or
Yeah.
like in surgery, when
Sure.
so if there's something going on in that regard, and as the second part of the same question, as I'm looking about the imager. So in regards to research, if research called the future is going to go in that direction, what are the areas that could be studied, whether using MRI or CT? All the different areas that has.
So I think the first question, mechanical valves are tricky in the current era because no one wants to take warfarin for decades. We've all seen patients who've been either under or over anticoagulated. But what about if we have a mechanical valve that requires either no anticoagulation or really less, like an Onyx 2.0, where you can really get to really low levels of warfarin. The problem there is that the patient is not going to be a candidate for a subsequent TAVR should that valve fail. And none of the mechanical valves are truly perfect in terms of longevity. If we have a better mechanical valve, that would be useful as well. How about a valve that's a human valve that we take some of your skin cells and we program it to be a valve interstitial cell, and we proliferate that, put it in the freezer. And so if you need a valve replacement in 30 years for you, maybe plate that tissue onto a valve scaffold, which is biodegradable, and we can give that to you. That way you have your own cells. The scaffold is biodegradable. That's been done in sheep. But the sheep story, I've been trying to follow that. That was kind of in vogue 20 years ago, and I haven't seen a whole lot of long-term data with the sheep. But the ones they showed that being explanted looked like a pretty normal looking valve. But wait and see what could be in the future. But regarding the imaging, imaging continues to evolve and get better. I think we're doing things with MRI now. CTA allows you to look at both the calcification and the fibrosis of the valve leaflets, which could be important because sometimes you can have a very stenotic valve without a whole lot of calcium, or vice versa, a lot of calcium and no stenosis. So it's a work in progress. I don't have a solution except that it will continue to get better. And maybe get more confusing with time. Yeah, good question. I'm not aware of this. There is this whole issue of what's going on in the bones versus what's going on in the valve, you know, and is calcium supplementation, hurting the valve, helping the bones. It's yin and yang, but I'm not aware of, clearly there's some diseases that can cause a lot of calcification in other organs. That rare conditions. I'm not sure I can answer that question correctly, so I don't want to suggest that I know something I don't know. It's a good question. Good question. But I'm not aware that people with aortic stenosis have a lot of extra cardiac calcification.
Thank you. Thank you. And the concern always when you're doing intervention is, are you going to actually improve the patient's symptoms with? And I think that's
well stated.
Yeah, where you said before, you said way up.
Oh, okay. Good question. So no, so previously this was kind of under the radar, and so I'm talking about patients I saw in the 1990s, who in retrospect, maybe they really had this syndrome, and I didn't pick up on it then because the gradient was low. So now, yeah, I throw everything I can at that patient. Let's get multiple echoes. Let's make sure we have a really good echo to get the gradient with all from the suprasternal notch and so forth. How about cardiac CT and even perhaps MRI? But who's going to pay for all of that in all of our patients? So it's the multimodality issue sounds intriguing. Even that doesn't necessarily help you. So a lot of it is just taking clinical judgment. Okay, take a deep breath. How symptomatic is the patient? And should we be considering intervention or not? So that's why I thought the whole thing with the clinical skill set is probably the most important thing. But even that's not perfect. I wish I had a better answer. So Partha, what do you do with your patients who have low flow, low gradient, normal EF? What's your way of paradoxical low flow, low gradient?
That's the most challenging.
Yeah. And it's about 35 to 40% of the patients we see.
Multimodality imaging is the most important thing, and well, I think I always believe in a multi-parametric decision rather than it is difficult to get all consistent, but of the valve and in how it's moving and on the echo itself, basically giving the correct diagnosis of low flow. Then CT always has helped. If you can get the calcium, great. If you cannot, I know some centers that they've attempted to increase the flow, but typically the vitamin stress. I'm always looking for funny advertising, an excuse to send them for surgery or a procedure. That always is a
yes, good point. Yeah. Glad that you struggle with this too.
So, wonderful talk, and it's great to see you again. I had a question that was sort of you alluded to, but also Dr. Yanamala, and of course, Dr. Sim. So in terms of artificial intelligence, we have studies like the Cardia study of young adults, and unfortunately, our echoes weren't that great in terms of parsing out all the things we needed for aortic. But my question is, can you very young at the time, and and their EKGs, look at their LP little a, look at the genetics, and then design a trial that says, let's look and see who developed aortic stenosis 5 or 30 years later. And then perhaps, we'll have a better, fractional shortening of the LV in these young folks. Predictor who's done heart failure.
Yeah,
10,
yeah,
15 years later.
yeah.
So maybe you don't have to have the greatest echoes 30 years ago. You'll have others.
Yeah, so Partho was showing me some data, or we were discussing, where you can start seeing changes in left ventricular function in patients who subsequently develop aortic stenosis before they have aortic stenosis. So there could be other signals there that we could be capturing. And the genetic data also are kind of, they're not mainstream, and we don't do genetic testing in most of our patients, but there are some genes that also can be associated with a higher risk of aortic stenosis as well. LPA being the gene variant du jour right now. But question we have to do, I think there's so many issues here. Screening for these patients, identifying who's at risk of developing more severe aortic stenosis. What's our best imaging tool? How to follow these patients?
I think we've been here for a very long time. I think you must be really, really tired because it got about 4 o'clock in the morning. I thought I took a flight.
Yeah.
So thank you very much for spending this tremendous amount of time and your stamina. We certainly have tested that today. And thank you for everyone to be able to join us. And I think I wanted to just give a note organizing team, particularly Andre Bernard outside. Thank you. Just applause. Dr. Yanamala and others who are very together. And the next continuing on the same sequence.